So again, welcome to everyone, and today's is quite busy day, and the first talk today was about the management of ventilation during the. I will try to discuss a bit about induction and emergency of anesthesia. So yesterday we discussed through the operation. So again, we are back to these slides. The idea is that if we reduce the intraoperative atelectasis, yesterday we have seen some of the possible strategies. Today we will discuss more the use of non-invasive respiratory support to improve the safety at intubation. And then the second issue is to avoid post-operative atelectasis, and we will discuss which is the evidence, not much, about the use of non-invasive respiratory support at the time of extubation and eventually early after extubation, and some possible bundles to improve the extubation phase, which is not usually very much considered. Again, this is the slide that we discussed yesterday, but just to remind that after surgery there is occurrence of some amount of atelectasis up to 72 hours. So we will discuss if some strategies at extubation might help to improve pulmonary function. And this again is a study showing that at 2 hours postoperatively and 2 days postoperatively, with a quite large variation between patients. It was observed in very old studies that there was an increase in the amount of atelectasis at 2 hours and at 1 day postoperatively, and this was associated with a reduction in oxygenation and a reduction in pulmonary function test. These were the relationship between the amount of atelectasis postoperatively and the forced cervical capacity. You see here that these old studies showed a quite good relationship between the amount of atelectasis and the reduction in forced cervical capacity or forced expired volume at 1 second. So this study showed that if you have atelectasis after surgery, these might be associated with a reduction in pulmonary function test. So the idea was that we can create a strategy from pre-oxygenation, and we will discuss a little bit about the use of pressure support and PEEP and CPAP at the time of intubation, and some postoperative prophylactic non-invasive ventilation, and some use of PEEP and recruitment eventually, not much during the surgery as we discussed yesterday, but early before extubation to have possible beneficial effects after extubation. No, it's not working anymore. Probably. No, everything is no, because here is Dubai. Yeah. I don't know. So again, I would be back to the fact that the amount of atelectasis are relatively high in a relatively minority of patients, even if, as you can see here, quite a considerable number of patients may present an amount of atelectasis higher than 5% of the overall lung tissue. And this is again the study that I showed you yesterday, but it will be back to the analysis of the data. These are patients undergoing open abdominal surgery, and you see here the amount at the day 0, so before surgery and after surgery, of the whole lung. This is the amount of poorly aerated tissue, so the low VAQ areas. This is the amount of non-aerated tissue. And you see that we have around 3% of the total lung volume at the after surgery, so not much. There is quite a considerable amount of poorly aerated tissue, but not so much higher than you can observe before surgery. And the amount of atelectasis, as you can see here, are mainly in the dorsal lung regions and not at all in the ventral regions. These are the correlations that we found. We tried to reproduce the study in the 90s, and you see that we did not find a very good correlation between the amount of atelectasis after surgery. In our study, we computed the overall lung, so not only one slice, as in the previous study where we CT scan. Our study is for magnetic resonance, so non-invasive technique. And you see that we did not find really a very good correlation between atelectasis and forced vital capacity, or atelectasis and forced expired volume in 1 second. So it's not so simple as previous studies were trying to show, and we see also that our population was quite large. And again, this is remind you that what we found most importantly is that the saturation in air was very nicely to predict that those patients who have no atelectasis after surgery. You see when saturation is higher than 95, very few patients presented atelectasis higher than 3% of the total lung tissue. So first of all, the role of non-invasive ventilation at the time of induction, and especially we focused on the role in obese patients, comparing the standard balloon technique as compared to the use of non-invasive ventilation with pressure support or PEEP or CPAP. The technique is relatively easy. You use a mask in the patient and you ventilate the patients before induction with a pressure support. You see here the level of PEEP is set at relatively low level in order to avoid excessive leak at 5 centimeters of water, and a pressure support of 10 centimeters of water, FiO2 of 100 between 80% to 100. This is for 3 minutes. Then you induce anesthesia as induction of anesthesia, and at 100% or 80% you maintain a CPAP level of 5, and at this time you intubate the patients. In this way, you see here that this is the control group, a control situation. This is with non-invasive positive pressure ventilation. You see here the reduction in lung volume at the time of intubation with a standard balloon, and after 5 minutes the reduction in end-stage lung volume is maintained, and you see a major reduction from around 2,200 milliliters of FRC to almost 1,000 milliliters. So major reduction. If you use non-invasive positive pressure ventilation or CPAP, you see that the reduction in lung volume is much less, and this is maintained with time. So if you use non-invasive ventilation at the time of induction, you can intubate the patient more safely, because of course the maintenance of lung volume is also associated with the maintenance of oxygenation. In this particular study, when we perform also a recruitment maneuver, as we discussed yesterday, after intubation, you see that we even further improve the lung volume, but of course I showed you that just after extubation, we lose all this effect. About FiO2, again, to remind you that the major issue is when you ventilate the patients at intubation or during surgery at very high FiO2. You see here the progressive increase in atelectasis with time when patients are ventilated with high FiO2, but just at 80% or lower, you see that there is no increase in the amount of atelectasis. So if you use positive pressure ventilation at induction, and the FiO2 of 80% is more than enough in most of the patients. This was a study in which they tried to wash out the oxygen very fast. You see here the oxygen in expiration, and so we're using a PEEP during surgery. They try to wash out in few minutes the amount of oxygen as compared to the control group, and you see that they did not find any difference in terms of atelectasis area, even if they use some PEEP in this study. So this also means that substantially FiO2 does not play a major role to determine a higher amount of atelectasis. Otherwise, you would expect with you start from 100% and you see that in this patient you maintain FiO2 higher for at least 20 minutes than the group in which FiO2 was washed out much faster, and there is no difference in atelectasis. These are the WHO recommendation recently published, and you see that they suggest that adult patients undergoing general anesthesia with endotracheal intubation for surgical procedures should receive 80% fraction of inspired oxygen intraoperatively, and if feasible in the immediate period for 2 to 6 hours. So these are the recent recommendations. And in the study, this is the meta-analysis that they performed, and there are some major problems. First of all, you see that yes, they found improvement in this was related to the wound repair, which was significant, but you see here that the I-square, which represent the variability of the studies, was very high, around 50%, and this was significant. So this means that really this meta-analysis that was showed in this recommendation was not accurate enough. Further, they included this study with a very large number of patients, almost 1,000 patients per group, by miles, which was in favor of high FiO2. But this study is really the avoidance of nitric oxide for patients undergoing surgery. So it was not really the effect of oxygen. There was the effect of nitrous oxide. So if you don't exclude these studies, this meta-analysis is no more significant. Other meta-analysis look at the effect of FiO2, higher or normal FiO2, and you see, for example, in this particular study, there was a trend towards a reduction in the surgical infection, but again, you see that the I-square was very high, and when the I-square is high, you cannot have any final recommendation from the data analyzed. Also related to the possible effect of nausea and vomiting, there were no positive effect on early nausea or early vomiting or postoperative nausea and vomiting together. This is the amount of postoperative atelectasis. You see again there were no major effect with a very high heterogeneity among the studies. So FiO2 does not seem to play any major role. One can say why not to use higher FiO2, but I can say also why not to use the lower FiO2 as possible. And again, this very recent meta-analysis showed there were no effects on surgical infection at higher or lower perioperative FiO2, and no effects on mortality, again, on higher or lower FiO2. So they concluded that the evidence is insufficient to support the routine use of high fraction of inspiratory oxygen during anesthesia. What about the possible role of FiO2 and PEEP at the emergency of anesthesia? For now, in this editorial, Goran and Estierna discussed the fact that positive pressure and recruitment might not have an effect, as we discussed yesterday, but the focus has been on the lung during anesthesia, whereas emergence from the anesthesia to wakefulness may be of even greater importance. So now there is an attention towards the awakening phase as compared to the intraoperative phase that, as we discussed yesterday, probably we cannot do so much. I have to stop the connection here. This is the study that we discussed yesterday, that at the end of any PEEP or recruitment, when we extubate the patients here, we have a loss of the end-respiratory lung volume or oxygenation. So the idea is that if you apply some PEEP here, you can have better results. So which is the evidence about that? This is a small study published some years ago, and this is at the time of extubation, and they look at the atelectatic surface after extubation, okay? These patients were extubated by using 100% oxygen before extubation. These patients were extubated with 100% oxygen and recruitment maneuver before extubation, and these patients were extubated with recruitment maneuver and low FiO2. As you can see here, there were no major changes in oxygenation after extubation, but they observed a reduction in the amount of atelectasis when the patients were recruited before extubation, and FiO2 was reduced at 0.4. Of course, this does not mean that these patients had worse outcome as compared to these patients. It's just the observation that there was less atelectasis in this group of patients. This again is a study that we showed yesterday. What they did here is that they applied 10 centimeters of water before extubation and recruitment maneuver in the intervention group, while in the standard group they just extubated the patients conventionally, and you see that this is the difference between the alveolar and arterial oxygenation, which is a sort of surrogate of shunt, and there was no difference in the group in which there was an intervention for recruitment and the effect on oxygenation at the time of randomization and after extubation in both groups. So this study did show that there was no major effect of recruitment before surgery, before extubation. This is another interesting study, very limited number of patients. They use a PEEP of 6 to 8 before extubation, and in one group they use higher FiO2 and lower FiO2, but again they did not find any difference in atelectasis from higher to lower FiO2. So at the end of all this story, this is the last one that I want to show you. They mix it together, FiO2 100% and 0 PEEP. FiO2 100%, 6 of PEEP, FiO2 0.8 and 6 of PEEP. And then at the emergency, after extubation, they use 100% without CPAP, 0.3 with CPAP, and 0.3 with CPAP, but they reduce FiO2 here. And substantially, they did not find any difference. So, and this means that substantially, there is not clear evidence that you can have something better if you manage FiO2 or PEEP before or just after extubation. So this makes some question if you have to apply some non-invasive support after extubation. And you see that there was no difference. It was not many patients, as usually in the French studies. You see around 100 patients per group. But there was no difference in PPC between the two groups. There was a trend towards a little bit better with high flow, but you see there was no significant difference. So, and this is probably the most convincing till now is the Spanish study. When they applied, you see, CPAP in 3 groups here, there was a trend towards a reduction in complication compared to standard oxygen, but it was not significant, and is within 3 to 4%. So we need a huge number of patients if we want to prove that. There is one study, is the PRISM trial, is on 4,000 patients. It's a UK study with some centers all over the world. We are not part of this study, that are testing CPAP for 4 hours after surgery as compared to standard. They randomized 2,000 patients right now, and we will see the results. Of course, the iProve trial, this is not encouraging in this setting. So we have no evidence that to apply non-invasive respiratory support to all patients without any selection might be really helpful to improve outcome in these patients. Now there are some new devices, and these I wanted to show you some technical issues. This is a very recent study that was performed by Niccolò Patroniti from my unit now, because this is the showing of the CO2 rebreathing by mask. So, because now we have also just one slide to discuss the technical issues, no? This is the in CPAP or pressure support, this is the conventional way. You see here you have a mask, no? And here you have a connection, and then you have the double connection at the Y, okay? And then you can do CPAP or pressure support, whatever you want. Mainly CPAP, it's easier. And in blue is the representation of the washout of the CO2. You see that when you apply the standard mask, so when you have the Y here, and you have the flow here at 40 or 50 liters per minute, you see that during expiration, you have, this is during inspiration, and in exhalation, sorry. So at the end of exhalation, and this is, you see that this is in blue, is the amount of CO2 at the end of expiration, okay? And you see that when you start to inspire here, you have a lot of CO2, because of course the washout here is minimal, and this is occur also, you see, during pressure support. If you use different mask, when we have a line of here, one input and one output, different, okay? You see that in CPAP you have a continuous washout in the mask, and you have no CO2 rebreathing. Here, even in pressure support, we have some more CO2 rebreathing, but much less. So the finding from this, I don't know which mask do you use here, is that when you use the mask after surgery, okay, because everyone is doing randomized trial, but if you apply the wrong CPAP, we have the wrong results in the randomized trial. The study that I showed, the high flow cannula was like that, and all the other studies, they used the CPAP in this way. So here is clearly demonstration that we have to change the mask that we use for CPAP or pressure support, and use mask with a double independent entrance and outlet.
The same things I think that we must use. I saw the slide about helmet.
Absolutely.
If you come back.
So I did not want to enter because the helmet. So the helmet. Absolutely, yes. I did not want to. Yeah. This is the helmet, and why I did not want to focus too much on the helmet, because I like the helmet since some years ago. I think we were one of the first group, and when also in Varese, to use pressure support like that. No. Now, actually, we don't use anymore.
Why?
Mostly because we use the full face, or because we found that full face allows a better synchrony you can do for ventilation like this. I know there is some studies now that are trying to show its effectiveness compared to mask, but we use much less the helmet. However, outside the ICU we use, but we prefer now full face, because full face is very well comfortable. And
these are for selected patients, not all patients.
For very selected patients, the helmet. No, I mean the full face, the new mask. I mean the problem were with the oral fascial, no? But the full face we kept also for a long time without any major problem. So now I think that the full face changed the way in which we perform non-invasive support, work positive pressure. I'm not against the helmet anymore. I like the helmet. What I'm saying that the full face changed our strategy.
If you have full face, I'm agree. But if you have a non-full face,
no, absolutely.
I absolutely still prefer helmet.
Absolutely. Yeah. So if you have not the full face and instead of the oral fascial, so nasal oral. I agree absolutely that the helmet is our first choice. Yes. Now we have more and more full face, and so we are going in this direction. But if you have not the full face, I fully agree that the helmet is a very good option. Now, even outside the ICU, in the ward, for hematologic patients or other type of support, we use the full face. More instead of the helmet. This is what we do in our institution. In other institutions in Italy, they continue to use more the helmet. This was shown because these are the new device, which are, this is the high flow nasal cannula, and these are the new device. These are, you see on the mask. We don't like to match this kind of mask or the helmet. Unfortunately, they did not. Now they can apply these new systems, or StarMed or Dimer, also with the mask with the double entrance. This is different because this is our Venturi system, which are very light. Because you see you have two entrances, and you have one for oxygen, and the other is the supplemental oxygen. This is the Venturi, and this is the PIP valve. And these are very light. So you don't need an additional system for Venturi. So this is a Venturi with the entrance of the air from the border. No, you see here the entrance is coaxial, and we found that the coaxial is more efficient. So with lower amount of FO2, you can get higher flow, and then eventually, if you want to increase, you have the bypass. So this was. In our studies, we found more efficient. But anyway, I don't want to enter into detail.
So the market now?
Yes, the market, yes. Both of them are in the market. And these are, now, for example, to transport the patient from the, a ward or unit to the ICU, we prefer to use this kind of device, mainly by helmet. You can do, this is also applied to the helmet in the same way.
You don't think that, sorry, Paolo.
Yes.
Think that the compliance in helmet, we can arrange a better compliance. In the long time, you can arrange a better compliance to understand better the compliance of the patient with the helmet. It's not rigid. Like, because I think that the helmet, in my opinion, the helmet
was born to perform CPAP.
Yes.
And for CPAP is good because you have high flow.
Yes, I talk about CPAP.
Sub-CPAP, I think that the helmet was designed for CPAP. So it was designed for to oxygen in the hyperbaric chamber. But then with the tent. But really, its application is for CPAP because you have high flow. We use 60 liters per minute. Never use less because otherwise you have more washout inside, less washout inside. So we use at least 40. And this system now, even this light system, they provide up to 80 liters per minute overall. Okay. So are very, very efficient. In this case, the helmet, the compliance of the helmet is positive because you have a sort of reservoir balloon in the CPAP. When we use this in positive pressure, so not in this, so as a pressure support, we used, but I think there is a little bit more complication. CO2 washout is not so efficient. So
we leave the valve also open.
Yes. So we don't use anymore frequently, almost in positive pressure. We use in CPAP. Okay. So I think we try to clarify these technical issues that I think are very important. So this of the mask, I think, is a major point, so for the next future. So this we can skip. Extubation bundles. Now I'd like to just to show you a sort of suggestion that are open for discussion. These are nice, was published in 2012 by the UK. First of all, the role of neuromuscular blockade we discussed yesterday. These are data from our Las Vegas study. These are the number of patients monitored for neuromuscular function, no? With twitch. Yesterday there was a lecture on that. And you see that we found in Europe that only 18% of the patients are monitored, very few. But interestingly, you see even patients who are at risk or develop a PPC that you would expect to be more monitored are monitored only in 25%, so 1 to 4. And so this opened the issues related to the fact that we don't monitor respiratory muscle function, and I fully agree, as yesterday was pointed out, that we should monitor. And now we have to use a TOF higher than 0.9. So to be very conservative, to before extubation, and obese patients even more. It started the Abu Dhabi internet and then it blocked the system. So the use of peripheral nerve stimulator reduces the incidence of respiratory and airway complication. This is the first message, and I think we have more and more evidence on that. The other point is the positioning. For example, for obese patients, this was discussed yesterday, and the extubation in sitting position might be considered at the time of intubation, mainly the ramped position as was discussed yesterday. Yesterday was shown the new device. We used the new device, which is this cone that you can put under the shoulder. I don't know if you use it. These are the recommendations that from Italian Society for Obesity Patients in perioperative, and we stated that a safe extubation strategy includes monitoring of neuromuscular blockade, and of course vigilance is mandatory in case of suspected OSA. We discussed yesterday, very important risk factor, and sitting position is strongly suggested when patient emerges from anesthesia, especially for obese patients. FL2, we discussed that. Another problem is related that in adults, deep extubation might be considered to reduce the incidence of post-extubation cough, and extubation should be theoretically performed mainly at the end of an inspiration. These are interesting data on the use of intravenous lidocaine, which might decrease the postoperative sore throat. And you see here that there were different groups, and interestingly, the last group here was treated with lidocaine intravenously before extubation, and they used also a reduced size of the tube. I'm not recommending, but just to think about these kind of things. And you see that the sore throat at 1 hour or 6 hours or even at 24 hours was much lower. So we are around 20% versus 40, or here around 60 to 50% as compared to other groups. So there is some evidence that lidocaine can help to have better comfort of the patient at extubation, and do not exaggerate in the dimension of the tube. I'm not 6, to me it's too small, but
it's also logical. It's also logical.
It's also logical, and so these are something that we have to take in account.
Lidocaine infusion or just the bolus?
No, just bolus. And so administration of intravenous lidocaine immediately prior extubation may reduce the incidence of throat and eventually laryngospasm. This is a meta-analysis, one of the few on this issue. You see not many patients, but quite consistent. You see, this is the effect, for example, of the laryngeal mask. We discussed yesterday, the use of laryngeal mask. There is some evidence that laryngeal mask may favor in terms of laryngospasm and emergency, but there are some patients, as obese patients, in which we should not avoid. We should not use, and we don't use. Personally, I'm not a great fan of LMA. I just, Why? No, in general. No, in some patients at risk, I'm not in general. For others, our colleagues, they use. We don't use too much in intensive care, but even for tracheostomy, of course, we don't use. Because some people use LMA at the time of tracheostomy instead of retracting the tube and the fibroscope. They use the laryngeal mask. They extubate, use the laryngeal mask, and use the fibroscope in the laryngeal mask while they are using the tracheostomy. We don't do that. I'm not against the LMA. I mean, this is. But anyway, in fact, there are evidence that when possible to use may be effective. So that's what has been proposed that following elective surgery, a patient directed with LMA may reduce the incidence of postoperative extubation, adverse events, and obtune the cardiovascular response. This is the efficacy of endotracheal lidocaine administration with continuous infusion of remifentanil, in this case attenuating tube coughing. You see the lidocaine group, very few patients, of course, here, and there was more patients without coughing in the lidocaine group. So lidocaine is something that might be considered. We don't use too much in intensive care, but we use more some corticosteroids in patients at risk of laryngospasm or laryngeal edema. We don't use too much lidocaine, but just to show this data. The extubation in the high-risk patients, of course, tube exchangers I think are very important. Now we have very much experience in patients with tracheal resection, very high lung tracheal resection of 10 to 11 rings, so very advanced. And now we learn more and more about the use of safety extubation in these patients. We use a lot of dexmedetomidine now in these patients, very helpful. And we use high-flow nasal cannula. I did not have here, what we also use is is in the obese presentation I put that, but the entry catheter. So now what we do is that we use when we extubate these patients, for example, with resection, We use the mandrine of the cook, which is very thin and long. We put inside, then we fix at the mouth, and so we have a sort of control of the airways, relatively control inside, which is not stimulating the patient. Then we have as a rescue the fast track, not the fast track, we call the laryngeal mask, and we have the Eintri catheter. No, we use a lot. We have there for any emergency. So I think that the combination of fast track with or laryngeal mask, but we prefer that we have the fast track, and the Eintri catheter and the fibroscope may help in whatever situation we are.
Tracheostomy, does it help? It's in the region.
In these patients, we cannot do that because we have just 2 rings left. 2 rings. The patient is like that. It's fixed with the chin. And when we never did that, but if we need the tracheo, you have to do transsternal tracheo. You cannot do that. I just mentioned because I think it's the top level of difficulties, extubation, and this is what we do, what we use in practice. And in this, dexmedetomidine helped a lot because we don't use any more opioids, so we don't have anymore any reduction in cough or breathing, so the patient is very well sedated, but comfortable. The cough is not stimulated, so we found and the high flow nasal cannula instead of the CPAP, because CPAP in this patient may create some additional effort, while high flow nasal cannula give just a little bit of PEEP, enough to keep the upper airways open and comfortable of oxygenation. So I think that changed a lot our extubation phase in this very difficult patient. Just tell you this story because this is we are now, I think, one of the centers that we do more on this. And the Eintri catheter, I know that, I don't know here, I think you know very well, because many people, they don't use too much, we believe a lot in the Eintri. I like that a lot. So the role of non-invasive postoperatively, we discussed a little bit before. There are some evidence that can reduce complication of survival, but you see very old studies, very few studies there. There are some data in obese patients showing that may reduce complication, but you see 2 studies, so not much. So the conclusion is that non-invasive after extubation, we don't know. But we have some evidence that when you develop respiratory failure early and you apply non-invasive ventilation, this might be helpful to reduce the rate of intubation. So the concept to me actually is that we should not apply non-invasive respiratory support, CPAP or whatever, routinely in all patients after, but if you are developing respiratory failure early, so when PO2 is below 300, so not waiting progression of respiratory failure, we should apply early non-invasive ventilation, pending that we excluded a surgical cause, of course, of deterioration of respiratory failure, which is the first point. So once that we are excluded a surgical cause, otherwise we have to go to the surgical room, we know that can be an effect of this. Okay. The final point is should we admit all patients at risk in critical care or not? This is a recent study coming from a large database from the EUSUS that we did some years ago. And you see that unfortunately, if you don't categorize well the patient, You see there was no effect. This is the mortality and patient admitted to critical care after surgery. If low patients or high patients, there was no effect. No effect on the mortality. You see, and even the proportion of beds allocated to critical care was not associated with mortality. So probably we have to identify better the patients and to have better strategies on that, but not just to say, okay, these patients, or to increase the number of beds without any reason. So the conclusion were that I show you that atelectasis during surgery in postoperative period are not so huge as we expected before. Higher FiO2 at induction and during surgery may increase atelectasis, so we should not use too much FiO2. PEEP minimize atelectasis independent from FiO2, but we don't know if this can be clinically relevant. Lower FiO2 and PEEP at emergency and after extubation do not significantly affect atelectasis, as we have seen, and even outcome. We have seen some studies now showing that if you apply CPAP after surgery, overall does not affect outcome. There are so extubation bundles. We discussed xylocaine, LMA, blah, blah, but there are no well-powered and designed randomized controlled trials. Potential benefits of non-invasive, this is something we know more, in postoperative respiratory failure. So not as a prevention, but as a treatment. This, I think, is a major point. No apparent survival benefit from critical care admission following surgery. So this opened the question of the selection of the patients. And secondly, the role of emergency team. Perhaps we can move the patient to the ward and then eventually to have an emergency team to recognize early those patients who are high dependent or the MET or high dependency ICU, not monitoring areas, and so the role of intermediate care. And but regarding the intermediate, now we are developing a quite large intermediate care. What I think we should have the intermediate linked with the general ICU. So I don't think that it's good to have an intermediate separated from the ICU. So the idea now, I discussed also with Jean-Louis Vincent on that he's against the intermediate. So he said, okay, you should have a large ICU, and inside the ICU, you organize your system, okay? Then you can have a second option, is to have the ICU, and then next to the ICU, to have the intermediate, which is very similar. In one, you are overall, and the other is just next. I prefer next because in the intermediate, I think you have the relative has to be stay 24 hours, very open, less activities. If you mix together, my feeling, so my experience, not my feeling, especially if you run very big ICU, is that it's difficult now to mix together these two levels of care. So this was the first. If you have any additional question, I think we discussed most of the points.